Over a period of time through our ophthalmic practice, we understand that USP matters in present day. Previously, it was seniority, experience, how long you have been in that place, all these mattered. But today, we understand that there is crops and crops of new things coming up in our own area of practice in various dimensions. And these make it important that you should, over time, reinvent yourself and reproject yourself in, or rather repackage your practice in a better way. That I think all of us accept and understand to maintain our practice hold in that particular area of practice where we are practicing. So in this way, we are in the whole idea of this session is to make you understand that by going into dispensing spectacles, you can have a very good ancillary to your practice in all possible ways. In the ways by which you generate revenue, in the ways by which you attend to your patients, the way by which you make it more comprehensive so that he is not at the mercy of another person to dispense that spectacle, and in just in case that spectacle is not to his satisfaction, that patient tends to roam between that opticals and you every time, because he goes there, that person says your doctor gave this prescription, go ask him. You tell that this is not properly made, go ask the opticals. The patient tends to run 2 or 3 times between you two and then end up skipping both of you for the next time he goes for a spectacle check. This is the practical reality of dispensing opticals. It is rather a liability for us to see to that these are proper, more proper than the prescription which we sign. The dispensed good also has to be pakka and proper for the satisfaction, because patient spends dear money on it. That much money he spends today, in fact it is more dearer with the newer glasses and newer frames. So it should be having some amount of good value to him, to give him that good value. What are the better ways by which we can repackage or reinvent by our refraction system is the aim of my talk. Over time, we understand that refraction is becoming more automated and automated. Chair units are almost ubiquitous nowadays. I still believe that there are conventional doctors who still practice with a table and chair. But having a chair unit and having everything comprehensive makes it very beautiful, because patient sits in one place, everything is done from an indirect ophthalmoscopy, vision test, everything, right and left and center. But what all we can add to this chair unit, what all we can make value additions to this chair unit will make a matter. I'll introduce you to a small video where you can see the conventional refraction which was being done. In fact, we are all very sentimental about this trial frame, about the trial set and the first Snellen chart which we bought. We are all very sentimental about it. We tend to keep it forever. Most of the things which stay with us for the longest period of time, I believe, is the first trial frame and first trial set which we bought. But you understand it is very cumbersome, very tricky, and the patient concentration time today, the average person's concentration time today over the advent of various electronic devices, communication devices and the social media is split seconds. They can only retain their concentration for split seconds. Making him to sit in a chair for 5 minutes to do a refraction itself, the patient thinks you are outdated. That is today's idea. He wants to do it instantaneously. He wants to sit in a chair, you spend 1 second with him, you give him a proper prescription, he is very happy. That is reality. But conventional refraction with all these trial set, trial frames, everything, you drop these lenses once or twice, our patient tends to take it off. Our patient says, you change the axis, sir, I'll tell which is correct, and keep between the axis your life will be hanging, because the other patients will be waiting in front of your consulting room and he will go from 100, 105, 90, 95, like this he'll take all the time out of you. So for both you and your patients, time is premium. So what can you do for it? You can buy a phoropter. A phoropter is an interesting device which puts everything into it. It's just dials and knobs. These dials and knobs will look bit bearish at the first instance, but it is very easy. Most of the times we don't do refraction. We hire people, we appoint people to do our refraction. So these people are small youngsters who have done refraction in a course in some major institutes. So they will pick this up very fast. And trust me, it will look very good if you use a phoropter. because most of the advantages which a phoropter give are rather the disadvantages of a trial set. All the lenses are available. Even a Jackson cross cylinder, if you are very keen and particular, you can use the colored lenses. You can use even the Maddox rod is present inside it. Pinholes, all the cylinder combinations, spherocylindrical combinations, everything you can put. And all these knobs and dials take only a practice of 2 to 3 days. It's not like you'll have to learn it with a learning curve. It's very simple and straightforward. You switch these dials, then the patient understands you do it differently from your neighboring practitioner. That itself gives you a big USP, and this USP will add to your successful practice. I'll just show you a video, small video of how this is done. The dials are just brought into the optical axis, taken out, and the dials have the spheres, the cylinders. Both eyes can be simultaneously done, and the end prescription can be written off from the values in the phoropter. The near vision add also is very easy. You have to just hold the near vision chart nearby at a proper distance and add the near vision add also, and get up a proper prescription. So a phoropter, in fact, can do a huge difference. The conventional phoropters are roughly around 1 lakh, and even the Topcon phoropters, they go to around 2 lakhs, 2.5 lakhs. But I think it is worth investing. It can do lots of things with so much of finesse, and in fact the phoropters have become now digital also. You don't need to go to the dials. They give a print screen in front of you. So you can sit in this chair or rather the examiner's chair, patient is in his chair, in the chair unit. You can operate the console in front of you, and this console can change the lenses in that. That much technical and modern it has become. If not this, the previous version, or if you are very keen and interested in the sophistication, this version will make a huge difference. The next interesting area which hasn't changed over time is the Snellen's chart. It has 7 lines, and between the 7 lines it takes around a lot of your practice time. Patient goes from the 6-6 line. You show him, any postoperative patient, you show him the 6-6 line, you are doomed for life. Because patient will not leave your consultation room till he reads that 6-6 line convincingly to him. He'll keep reading and say, sir, I can read, but it is blurred. You will not understand what that blurred means. Then you'll have to take a textbook on aberopia, which is now 2 or 3 volumes, and read and not understand any of the lower order or higher order aberrations, and then go start scratching your head. Only thing we keep saying to the patient, will get better with time. In fact, that is that one holy sermon which keeps us practicing. It gets better with time. And patient should trust you over time. Today, the patient doesn't trust you with time. That is the problem. So what can we do with this Snellen chart? With the Snellen chart, we can have a chart projector. The chart projector can project whatever line you want. If your consultation room is not that proper distance, now you have a mirror reflection to get that 6 meters. But this chart projector can be set up for 3 meters itself. It can be set up for whatever distance you want. And the chart projector can be in any vernacular. It can be in any vernacular. It can be numbers. It can be images, figures. It can also project charts of the color vision test. It can also project charts of the basic counseling conditions like a diabetic retinopathy, a glaucoma disc. All these also you can show to the patient. So it can also be a counseling, half counseling, where you prime the patient for a procedure and send him to your other staff to take over from there. The chart projector has lot of advantages which makes it very sophisticated, very beautiful, and trust me, today patients like a screen. Whatever screen it is, whether LED, LCD, plasma, or whatever, they want a screen. They don't want a mirror. They hate a mirror. And this screen, if you can have in your practice, it can do a huge advantage, huge difference to the way we see these things. Children, adults, illiterates, everybody you can handle in that seat itself. You need not be very discriminative. I'll show you a small video by which we understand how it is useful and what it does. It today even comes in these iPads and notebooks. You can even mount them on the screen. But a conventional chart projector is bit more clear and more that the proper contrast sensitivity which we should have in the test conditions, it can mimic better than a screen, because screen will have its own glare. So it can bring in whatever you want with touch of button. You can change things. You can show only the 6:18 line and send the patient home because the patient understands he has read the last line. So that gives you a huge perk for your practice also and saves your time. and all these things you can get by these chart projectors. They are very convincingly priced nowadays. From 50,000 onwards, these LCD projectors you can have, but the proper projector with the screen charges around 1.5 lakhs is charged. Auto refractometer with K we have accepted. I think it has become ubiquitous. It is nothing new. All of us have. Previously we had a AR. Now we understand the K makes a huge difference in the cataract calculations. So now we have auto ref with K. That and all we have. Today we have auto ref with K with slit lamp imagery also being integrated into it. There are companies which bring auto refractometers which have slit lamp images. The images can be of a cataract and IOL positioning. It can be a SPK. It can be episcleritis, pingicula, pterygium, whatever. You can just take not a proper slit image, just a diffuse anterior segment image. You can just click as the patient is being seen. So you can use it for counseling also. You can show that these are the things in it. So that also becomes a huge advantage. I think we have taken it. There is no difference of opinion that this becomes very important in our practice. Another interesting thing, if you are going to opt for an optical device, is to stock the frames. Dr. Nirmal told you that stocking frames becomes a very dynamic process. You just cannot buy 100 frames and think that it will run for 10 months. It doesn't happen because the models change, the frames wear out, they look old, all these things will affect. And you might stock frames which you already have and then go into lock your good money on wasteful things. So these things should not happen. It's a dynamic process to keep the stocks very comfortable and very competitive to your area, to your practicing area. So in that today, if you want, you can have these frame selection softwares. Patient can sit, patient's image is captured by the screen, and the screen gives all the frames whichever you have in stock. It shows it on the patient's face. Patient can take how many images of it, send it by WhatsApp to his fiancée, would-be, or whatever, and they can communicate and say that it looks nice or ugly on your face, and then patient can decide upon it, and then he can make an order. Because today the opinions are shared very fast. So it can be done in split seconds, and the patient can have a convincing decision that this is the frame I want. Previously it was not so. That will change with these modalities. One another area which I think is a huge perk for our practice is pediatric refraction. Whether you are individually a pediatric ophthalmologist or you are a general ophthalmologist who has a wide practice where the families tend to bring the children to you because they think you are a senior doctor who can give a best opinion, because most of the times the school checkups are happening right day left, every day, every week. I think one of the optical companies or rather outlets in your area will go to the school and do a school checkup and give them a printout of an auto refractometer and say that glasses are very needed for that person. If you look at it, it will be 0.25 cylinder at 10 degrees. For this, glasses is very important. It should be worn immediately, most probably that same evening, or else the patient will lose, or the child will lose his vision. This is the counseling which is done by the very unruly optical stores and outlets in your place. They go to school children and spoil their whole idea, and the family take it from me, panics. It panics when suddenly somebody says that a glass for the child is very essential. It becomes a very crucial decision for the family to make, so they come to you. So if you are going to see these children, there are certain norms and guidelines which you have to follow, because it's not adult ophthalmology, it's child ophthalmology, and this is totally different from the way we see adult patients. So trying to learn these perks will help you very much, because these children, if you are going to convince the family with the children, obviously the family will never go from you. It will stay with you. All the grandparents will come to you for surgery, the in-laws will come for surgery, and your practice will like a geometric progression. If a child in a family is treated well, I am sure the whole family appreciates you so much and brings the family to you. So what do you do for a child or a pediatric refraction? Nothing much. You buy lot of cartoons, lot of visually appealing devices to the child, and make the child feel at home in the place. Or you can do also one another small trick. One of your optometrists, you can send them to a nearby place which has a good pediatric unit, and ask them to get trained for that particular checking, because I'm sure those people in that bigger place will have better experience over checking children, so they can tell your optometrist 2 or 3 tips which he can come and follow in your place. And these tricks, take it from me, are very wide. Whether you need to do how to do refraction, how to do vision checking, whether you need to dilate or not, whether T plus is enough or you need cyclopent, whether you will have to atropinize the child, whether you have to do accommodation balance, all these are very extensive. It's not like an adult at all. It is not like an adult at all, take it from me. So all these decisions are very complicated and cumbersome, and all these decisions have to be made by you, and finally you have to arrive whether you have to give a glass to the child or not. For that exercise, an easy way out is to use one of your optometrists to go for a training in this pediatric checking in a place. Because children will take lot of time, children will need lot of energy and lot of personal attention to reciprocate your checking process. What are the recommended eye examination frequencies? There are a lot of formulas each person use, but I think this will be one good table by which we can go. All the school-going children should be, as they go to school, they have to come for an eye checkup, and probably or preferably every couple of years from then if they are all right, or every year from then if they have some error. This is a usual thumb rule which I follow. I think that will be a good thing. So take it from me, over the time, refraction practice has changed as much as our operation theatre has changed, as much our LASIK suit has changed. Refraction also has changed, but somehow inertia in the refraction setup is that because it is relegated to others, it's not being done by you, and it is also done in a place which is unseemingly in your whole clinical practice. You keep it in a small dingy corner, so that much of time and energy need not be devoted anymore. It can be increased, and your practice can be in that process enhanced. A good refraction unit creates a very good first impression on the patient. Take it from me that first impression will matter a huge in the way your practice becomes a success or multiplies and becomes better. Thank you, ladies and gentlemen, for your patient listening.